Hey everyone. Oh, it is bright. My name is Dr. Tran. I'm with the USC Medical Center. Thank you so much for giving us the opportunity to present our data on the 5-factor modified frailty index as a predictor of post-operative outcomes following gastrectomy for gastric cancer. I have no disclosures to announce. So as we're aware, gastric cancer remains a major worldwide issue. It's the 5th most common malignancy worldwide and the 3rd leading cause of cancer-related deaths. Treatment for stages 1 through 3 gastric cancer is surgical resection, including partial and total gastrectomy. However, these are associated with significant risks, including anastomotic leaks, esophageal strictures, and post-gastrectomy syndromes. So it's important to identify patients who are at increased risk for postoperative complications to see if they may need some individualized preoperative planning to mitigate these risks. Frailty is a condition that's characterized by increased vulnerability due to multiple stressors due to a decline in functioning across multiple physiologic systems, and it has been associated with significant risks of falls, hospitalizations, and mortality. There have been several metrics that have been proposed for objectively measuring frailty, including the Canada Study of Health and Aging Frailty Index, which is a 70-item scale, and the 11-factor modified frailty index, which includes 16 variables mapped to 11 factors from the ACS-NSQIP. So more recently, a truncated frailty index, the 5-factor modified frailty index, was proposed. It includes these 5 variables that are included in the NSQIP data. This metric has several benefits, including that it is concise and easily calculable compared to longer metrics such as the mFI-11. It is multifactorial, meaning that it may better capture a patient's physiologic condition compared to metrics such as age, and it's an objective metric, whereas metrics such as ASA are subjective. Since its development, it has been shown to be an effective predictor of postoperative outcomes across multiple surgical subspecialties, but its use in gastrectomy for gastric cancer is less well understood. So the aim of this study was to evaluate the predictive ability of the mFI-5 by analyzing its association with 30-day adverse outcomes following gastrectomy for gastric cancer. So for this study, we queried the ACS-NSQIP databases from 2011 through 2021 for adult patients undergoing partial or total gastrectomy for gastric cancer using ICD and CPT codes. We stratified the patients into 3 groups according to their mFI-5 scores, and we compared preoperative characteristics and postoperative outcomes across the 3 groups and utilized univariate and multivariate analysis to evaluate the association between the scores and postoperative outcomes. We included 7,438 patients. The largest group was the non-frail group with 40.8% of patients, followed by the moderate frailty group with 37.7%, and the severe frailty group with 21.5% of the cohort. The most common mFI-5 variables in the overall cohort were hypertension and diabetes. And we found that high mFI score was associated with male gender, higher age, higher BMI, Black race, and higher ASA class. Non-frail patients were more likely to be smokers, but higher frailty patients were more likely to have preoperative conditions such as bleeding disorders, steroid use, and preoperative transfusion requirements. For this study, we analyzed overall outcomes, which is the presence of any adverse complication following surgery, and serious complications, which included a presence of any major complication that's listed on the following slide. We found that with higher frailty, there is an increased rate of overall complications and serious complications. And this is the list of the complications included in serious complications. Again, we found that there was an association between higher mFI score and complications such as transfusions, septic shock, MI, cardiac arrest, stroke, failure to wean, unplanned intubation, and pneumonia. We also found that patients with higher frailty more commonly had readmissions, 30-day mortality, and non-home discharge. We performed multivariate analysis and included preoperative characteristics such as age, BMI, and preoperative comorbidities in our regression analysis, and we found that severe frailty was associated with a higher likelihood of overall complications and serious complications. We found that moderate frailty was an independent predictor of septic shock. However, there was no significant difference between severe frailty and non-frail patients. Patients with severe frailty were more likely to have MI, and patients with moderate frailty were more likely to have moderate and severe frailty were more likely to have acute renal failure, failure to wean, and unplanned intubations. Furthermore, both moderate frailty and severe frailty patients were more likely to experience 30-day mortality and non-home discharge. There were several limitations to the study given its retrospective nature and the data source. There may have been input error in inputting data, as well as coding errors that may have caused us to fail to capture some cases. There is potential for selection bias. We did exclude patients who were missing data for any of the mFI-5 variables, and obviously we're only collecting data from surgeons who are participating in the NSQIP database. Furthermore, we're limited to the variables included in the NSQIP database, so we're missing some preoperative characteristics such as TNM staging and mental acuity, as well as some postoperative complications like anastomotic leak that we couldn't study. So in conclusion, we found that severe frailty is an independent predictor of overall and serious complications. Compared to non-frail patients, moderate and severe frailty patients are significantly more likely to experience 30-day mortality and non-home discharge following gastrectomy for gastric cancer. And these results suggest that the mFI-5 may have utility as a concise, easy-to-use risk assessment tool, allowing surgeons to identify high-risk patients who may require preoperative optimization, which may help mitigate risks following gastrectomy for gastric cancer. Thank you, and I'm open to any questions.